Okay, hi everybody. Welcome to another ETP, our number 9 for the series, ETP SESA webinar series. I'm welcoming back Peter Caine from the OWIA to cover the injury management. That's on sale from the previous one, injury prevention. Just a couple of housekeeping things before we get into it. Feel free to turn your cameras on today. Caine requested to provide more interaction with everybody if people would like to turn their cameras on. If you have any comments or questions during the presentation, I will be watching the chat once again. If you're wanting to speak, Caine is wanting more interaction, so please feel free to turn off your mic and have a conversation. Otherwise, we'll have a question and answer at the end as per usual. So without any further ado, we have Peter Caine. For those that didn't make the injury prevention webinar, Peter Caine is a specialist in sports and exercise physiotherapist. He is a medical services and rehabilitation manager at the Olympic Winter Institute of Australia and has been the senior physiotherapist with the Australian Winter Olympic team since 2005. So he's worked with many of our great athletes. He is also a clinical educator and lecturer at the University of Sydney, La Trobe University, and the Sports and Exercise Physiotherapy Australia. His interests are focusing on developing and sustaining successful high-performance programs in elite sport. Clinically, his expertise lies in exercise prescription and program design, both in returning to sport settings and in optimizing performance. So I'll hand over to Caine now to share his screens. But again, feel free to show us your lovely faces tonight, everybody, as we get underway. Caine, over to you.
I think we're out of time. Thanks for that. See you later, everyone. No, I was just thinking, thank you for the invitation. It's great to be back. But I've just realised if we've got to do a session on injury management, then it means no one was listening for the other one, the injury prevention. We shouldn't be in this space. But I suppose, you know, despite our best intentions and all of the strategies that we discussed last time that we can put in place diligently, accidents do happen, and you know, from time to time we do get it wrong. We might be involved in an accident, which can result in injury, or we can just get the balance wrong between what we're asking our bodies to do and what they're actually prepared for. And when we get that mismatch, that's called a training load error. And in fact, funnily enough, that's responsible for nearly all of the non-contact injuries that we would face in a sporting context. So that's 75 to 80% of injuries that we manage as a result of training load error, which is, as I said, just where you get a little mismatch between what you've prepared your body for and then what you're asking it to do. So I don't actually have a lot of slides this evening. I do want to talk about the philosophy of acute soft tissue injury management, which I think is a really important foundation for us when we're thinking about how we're going to take care of ourselves if we do sustain an injury. There's been an evolution, I suppose, of the approach we take to soft tissue injury management. And I'll keep saying soft tissue injuries. When I say that, I mean muscles, ligaments, tendons, these types of things. But interestingly, you know, bone and other tissue also responds in a very similar way and is managed in a very similar way to how I'll describe this approach. So it's pretty good rules of thumb. You know, cast your mind back if there are some parents here in the audience. You know, a few decades ago, if you hurt yourself, you rolled an ankle, you strained a muscle, you might have applied the RICE regime RICE, and that was about resting it and icing it, compressing it, elevating it. And, you know, we followed that sort of guideline pretty diligently for a very long time. But we've been the beneficiaries in recent years of quite a lot of rigorous work that's gone into looking at the value of that approach as opposed to other approaches. And there's been some really interesting learning that's come from that. And that's really what I wanted to share with you this evening. And the reason I wanted to allow for some question time at the end is just in case what I'm about to say might cause you some confusion based on your past experiences or what you might have been advised by people that have looked after you when you've sustained an injury. So you've got to remember that we're trying to stay right up to date with the current evidence base. We want to be providing world's best practice in the management of these injuries, because we're all kind of faced with the same challenge. It's never convenient to be hurt. We never really allow time to be hurt. We know the importance of being available for our training and in our preparation for competitions and in our athletic development. So, you know, we're all impatient to get better. And so we do have to push the physiology, you know, push the healing, push all these mechanisms to make sure that we're doing the best we possibly can, the most efficient way we can, so we minimize time loss, but also don't create a risk that we might be going back to our activities too soon. Let me just see if I can share a screen here. Let's see what happens when I do that and then that. With any luck, you are now splotching at a big splotch of blue with injury management written in it.
Yeah, we can see it. Looks good.
Excellent. Well, let's say that's the title page, so we'll move on. What I want to talk to you guys about is a bit of peace and love. And this acronym is really a fantastic summary of what the modern day 2020 approach is to acute injury soft tissue management. So you can see that we've in fact come a long way from RICE. We've got heaps more letters in the mix. We're taking in even more than the physiology, but it's based on a much better understanding of what tissues really need, both for their health and their best possible healing, and how some of the other interventions that we've used over the years, like compression and anti-inflammatory medicine, how and what part they play in the process, how important education is and understanding, you know, what's happened to us and what we should be doing about it, and then how we can slowly, sensibly progress our way back to being at least as good as we were before the injury occurred, if not better. So I want to spend a little bit of time talking about peace and love, but if we just zone in on what the letters actually stand for, you can see there that we're talking about P for protection. I'll elaborate on what that means a bit and how we use that protection approach. Elevation, you're probably familiar with. Where anti-inflammatory medicine fits in, and you can see the A there is for avoid anti-inflammatory medicine, so I'll definitely have to do some explaining there. That's anti-inflammatory medicines are things like Nurofen and Voltaren and Voltaren gel. If you're overseas, it might be called Advil, and then there's a whole lot of quite strong prescription versions of those drugs. Compression, that's probably one you're familiar with from the old RICE days. The E here is in education. And we'll talk a little bit about education and optimism, which is down in the love, but how they work together to actually speed up healing. And that's a really interesting sort of development in this space. when we look at load is a really important concept to try to get our heads around, and how appropriate loading is actually very powerful healing tool. But we do have to be careful with how we optimize that load, and how we can get a sense of whether we're doing a good job with that or not. And I mentioned optimism, and just looking at the notes under that, conditioning your brain for optimal recovery involves being confident and positive. And we'll talk a little bit more about that as we get stuck into this. Now, vascularization is quite a big word, but what we're talking about is groceries in, garbage out. If you think about it that way, you know, what do you want to bring into your house and into your fridge? Well, you want to bring the nutrition, you want to bring the groceries, and what do you want to try and get rid of and chuck out? And that's all the garbage. That's the byproducts, the leftovers, the refuse. And so that's where sort of this concept of vascularization comes in. But how we promote that, again, is a little bit different from perhaps how we might have thought about it in the past. And that ties in very closely with exercise and the role that exercise has in not only promoting healing, but also restoring all of those functions that we had before we got hurt. I don't know if Zoom has a hand up function, but I know Rebecca's going to be watching the comments section. So if you'd like to ask a question whilst we're in the middle of some of this, just pop in the comments that you say question please, and Rebecca will stop me, and then whoever'd like to ask that question, just take yourself off mute and put your camera on if you like. You don't have to.
Yep.
But go ahead and ask your question. We'll try it that way, Rebecca.
Yeah, no problem. Happy to do that.
All right, so let's zone in a little bit on these ideas here. So let's actually think about a person who's hurt themselves, a young emerging talent athlete showing a bit of potential on their skis, been hooning around on a day off with their mates. They've found a really fun little jump line at Perisher Front Valley. They've been getting a little bit more adventurous each time they go around, a little bit faster and a little bit higher in the jumps. But unfortunately on this particular run, just as they're going to hit the sort of biggest of the three jumps in the run, someone sort of skis in below where they're going to land, and they've got to make really quick, evasive action because they don't want to land on this person, and they don't want to get into any strife. So unfortunately, in making their big move, they get all their skis caught up and go down in a bit of a heap, and unfortunately injured their knee. And you know, for the purposes of this example, they got the whole trip across to the medical centre and the ski patrol, and they had some x-rays, and the diagnosis was that they've strained their medial collateral ligament, the ligament on the inside of the knee. And I picked that because that is in fact the most common injury for skiers, is hurting that ligament on the inside of their knee. So how do we apply these principles for that person? Now, if you're in the audience there and you're thinking, well, I've never hurt my knee. Well, good for you. But you might have hurt something else. You might have rolled an ankle. You might have overdone it at training one day and felt a muscle strain, or had something that was swollen and painful, stopped moving properly after you'd banged it into something. These principles will apply for all of those injuries as well. But just to give this description and this story context, we'll stay with our young athlete with a medial knee ligament strain. So protection. What we want to try and do there is protect the person and the injury from getting any worse. So we can use devices to facilitate that protection. We can reduce the weight bearing by giving this young athlete some crutches. so that they can still walk as normally as possible, but not have to take all the weight through their leg. And that is a form of protection. We could put a brace on the knee, and we do know for optimized healing of that injury, if you have your knee bent a little bit for the first couple of weeks, that really helps the healing. And so by putting the brace on and setting that particular position, we're also protecting the ligament. We know that in that position it can't get any worse, and it's well set up for healing. So protection can be in the form of equipment and bracing, but it might also be in the form of splinting or taping, or even just behavior. So there'll be some times when you've hurt a part of your body and it's a bit sore and swollen, but it doesn't need crutches and it doesn't need a brace, but your behavior can be a way of protecting it. And that might mean, well, I'm not going to do that thing that caused this injury again. And if it's something I do regularly, I'm certainly not going to do it again until I've recovered from this particular episode. So behavior can also be a powerful protection. And that's why you can see in the notes under that word, avoiding activities of movement that increase the problem or aggravate it, but also thinking about ways of protecting your injury with equipment. So that's our P. Where's the value of elevation? Well, this is a really important thing to have in the back of our minds. Is your body generally knows what to do if it has sustained an injury. It's got this fantastic inbuilt response. It's called the inflammatory response. And it's part of a cascade of bodily reactions that, is painful to help you change your behavior. So you do things that don't make it hurt. That's another form of protection. It increases the blood supply to the area because that's how it gets the groceries in. And all of these little cells that come flooding into the injured area have got jobs to do. Some of them are involved in scar formation and healing tissue. Some of them are involved in munching away at damaged tissue and the refuse and chewing that up and getting rid of it. There's a whole range of jobs that these chemicals and cells do when they come into an injured site. But the problem often is your body is so good at it that instead of just sending a few troops to do the job, can sometimes send the whole army. You end up with a lot more swelling and a lot more of these cells and a lot more of these inflammatory mediators in the area than you actually need. So you can control that by elevating your limb. So our young athlete here is going to spend some time, not all the time, but some time with their leg elevated. And elevation is a relative thing. And so we want to think about trying to have the injured area above our heart. Then we know there's definitely some gravity assisting with minimizing excessive swelling to the area. We do need this inflammatory process to happen. We just need to manage how much of it happens, that we get enough and nothing extra. Because obviously everything that comes into that area, we've got to get rid of at some point down the track. So that's where this avoidance of anti-inflammatory medicine comes in. And what I want you to think about there is, at least in the first 2 to 3 days of a soft tissue injury, to lay off the anti-inflammatories. Don't go to them as your first port of call.
Caine, just on that one too, I just got a question from Victoria while you're talking about this topic. She said, would you advise to avoid anti-inflammatories even after surgery as well?
That's a great question, because it is actually quite common for post-operative, which is again another form of soft tissue injury when you've had surgery, it is very common for you to have a prescription of anti-inflammatory medicine. Sometimes there's a range of medicines, antibiotics and pain relief and anti-inflammatories. And what I will say is, if your specialist has prescribed medication of any kind for you post-operatively, that you should follow that advice. And the reason I'll say that is because I'm talking in general terms here, and there might be quite specific circumstances that are only unique to your situation that your medical specialist knows about and has decided that on that basis, it's a good idea for you to take that medication. If you're faced with the choice yourself without medical direction to do a particular thing, then that's where these principles would come in. And that is just to wait a couple of days. Let your standard management of protection, elevation, compression, avoidance of provocative things, and some other actions that we'll discuss here, be your first line of defense. And then only after that sort of 96 hours, if you feel that your inflammatory response is really in overdrive and there's way more inflammation than is required, that's when we might look at the use of anti-inflammatory medicine as a second line to help manage the excess. What the studies have shown us is that if we go for the anti-inflammatories immediately, they're so good, these drugs, that they can actually prevent the inflammatory process from happening and therefore delay healing. And I said at the beginning, delays are the last thing that we want. So really what we're getting at here is to allow the inflammatory process, because it's the first step of healing, to establish itself, but again, only with a few troops, not with the whole army. The anti-inflammatory medicine might be appropriate in some circumstances after 3 or 4 days if you feel that there's too much inflammation in the area. We might be able to come back to that in question time, because it is sometimes not an individual's experience about when to have those medications and what advice they might have received about taking them. So we can explore that a bit further at the end. So compression, of course, that one seems to make a lot of sense. Compression facilitates the garbage out, funnily enough, as well as controlling in a supportive way the pain. So compression can be a form of protection as well. Some people use it with the view to reduce the swelling, and there may be a small argument for that. But the most effective swelling reduction is actually using your muscles gently, where they swell and relax with the contractions. And you can imagine that that is like a pumping action to pump out the swelling. So compression on its own is not nearly as effective as compression with some muscle pumping happening. And for this young person who has injured their knee, where the swelling has sort of tracked down from the knee into the calf and ankle, while they're lying there with their leg up, they could, within the limits of the brace, if they have that on, bend and straighten their knee. Won't go fully straight because it's being protected by the brace, but it can bend up. But they can also point their toes and pull their toes towards their nose, which gets their calf acting as a really useful pump to push that excessive swelling out of the calf and ankle area, because swelling there isn't going to help the knee healing. And so that's a useful way of getting rid of that excess swelling we were talking about. And so that brings us to education.
Oh, hang on one sec.
Oh,
one more question, Peter.
Great.
Great. This one's from Amber. She said, why does it say avoid icing after avoid anti-inflammatories? See how it says avoid an A, how it says avoid icing at the end?
Yeah, so you can see in, if we just go back a slide, let me see if this will work. Peace and love, there's no ice anywhere there. Do you see that? Whereas the old rice regime, rest, ice, compression, elevation. Ice, ice is getting a really bad rap in recent times. The idea behind ice was that the cold caused constriction in your blood vessels. And if the blood vessels were kind of narrower because of the reaction to the ice, then blood couldn't flow through them, and that would therefore reduce the swelling. It's pretty basic concept. Now, there's a whole lot of physiology going on that is probably beyond this talk. But we've actually got a couple of circulatory systems. One's the blood system that you're probably all very familiar with, but there's also a lymphatic system, which is another very important system, particularly in relation to soft tissue injury and healing. But we actually want to promote an appropriate amount of blood flow, and we've got to be careful about how we control the blood flow. And the studies around ice and their effect on blood flow are very poor. It really doesn't show that there's much effect at all. To get the effect, the tissue needs to be cooled, and the ice on the surface doesn't really cool the tissues very deeply at all. And therefore, it doesn't really have much effect on inflammation or swelling. So where is it useful? Because I really think there is a role for ice, but it's not in the anti-inflammatory stakes. It's actually in the pain modulation stakes. So ice can also be a distraction, like rubbing, but it can also affect the signaling of the nervous system back to your brain about what's going on in the tissues. And it can have an analgesic effect like Panadol or a pain relief. So avoid icing as an anti-inflammatory is what that point makes there on the A. But if you've got a lot of discomfort with your injury, then ice can be a really helpful non-drug way of reducing your pain. So I hope that helps, and we can come back to that one too, because they're usually the biggies, anti-inflammatories and ice, when we're talking about modern day soft tissue injury management. So your audience, Beck, is right on the ball here.
No, that's good. That's good to know. They're smart bunch.
Yeah. So we do try to educate, you guys, if you do hurt yourselves. We don't want to try and be right over the top. We try to pitch the education at the appropriate level, and we don't necessarily want to give an explanation that will cause you worry or concern, but mainly education about how active you can be in your own healing, actually. That there's not a great deal of benefit in the early days, and not much really throughout the whole process, value in passive therapies. So that's things where you're just lying there still having something done to you. Massaging would be a good example. Dry needling, ultrasound. There's thousands of modalities, we call them in physiotherapy, that are really just time wasters. There are some value in some of those therapies for pain modulation that calm your nervous system, but against the benefit of doing other things in that same time period, you'll get more bang for your buck doing the other stuff. Wanting medical imaging early on in an injury also is something that we don't often encourage unless there's doubt about what's going on. If the diagnosis is clear, we wouldn't really be chasing medical imaging quickly. We'd only look to that if we weren't getting the response that we were expecting. So if your therapist isn't chasing imaging straight away, that's okay. It's not because they're haven't thought of it. It's just they've weighed up the benefits and risks, the cost, etc., of doing that. And if it's not going to change how you're being cared for or the diagnosis in the first instance, it doesn't really have a role to play. So from peace, we go to love. I mentioned in the beginning that loading is really, really important, but it's appropriate load. We call it optimized load. And so that young athlete with the injured knee, loading could include skiing again or running, but clearly that's beyond the tissue's capability at the time. So it has to be appropriate or optimized load. And that's where, a professional, some guidance could help you. But if you don't have a therapist to talk you through that, then if you used pain as your guide, you can think of that a number of ways. You could give the pain a score out of 10, where 0 was no pain, 10 out of 10 was the worst pain you could imagine. A pain score of 0 to 2 or 3 is kind of, I wouldn't go as far as saying a good pain, but that's an optimized loading of the tissues where you're not causing that tissue any further damage. You're probably giving it enough stimulus to actually get a healing response. If you gave the pain score a score somewhere between 3 and 5, then I think that's a score you need to be cautious about. You'd need to look at how you felt after you provided that load, and you might actually need to back off a little bit because you're getting up into an area where you might be provoking prolonged symptoms or causing some increased swelling after that type of loading. And then loading beyond 5, we would discourage that type of symptom response. So that tells us that it's not a very good value to push on regardless of the amount of pain. Your body's trying to tell you that it's not coping so well with what you're doing. You want to come back to that sort of low level, 0 to 2 or 3. And then you can be confident that you're doing enough to help the tissues heal, but not so much that you're setting yourself back or delaying healing. So optimal loading is really important. If you think about the old adage of rest is a form of loading as well. Rest is the absence of load. And so when we compare people that have had soft tissue injuries that use a rest strategy for the first week of their post-injury care, compared with people who do optimized load, which is just enough stimulus to do something in that 0 to 3 pain range, the difference in their recovery is quite dramatic and continues right through until a year later. It's quite dramatic in ankle injury rehab. So it tells us that the loading or lack of it that you give your soft tissue injury, even in the first week or 2, has a big impact on how you go even up to a year later. So we want to get that loading right. We want it to be optimized. We need to respect the pain. We need to utilize our protection strategies because the protection actually lets us load optimally. That's how they work together. Optimism is about your beliefs, believing that you're in the right place at the right time with the right people and the right strategies to get better. And that outlook has a huge impact on how successful your recovery is. And so that's really interesting because that's got nothing to do with physiology. It's got nothing to do with protection, compression, elevation, low. It's got nothing to do with that. It's about attitude. So if you believe that you're going to get better, you're confident about the fact that you've got all of the tools you need and the wherewithal to recover, then you will have actually a much, much better recovery than someone who's a bit doubtful about that. So get educated, find out what you need to do, start doing it, and you can have that confidence and be positive. And through that loading, through that pump mechanism we talked about with the bending and straightening of the knee, the squeezing of the butt cheek, the flexing of the ankle, we are promoting that vascularization. That's the best way to do it, because we can control that and we can get the benefit from the movement as well as the healing. And of course, that leads into more and more types of loads through exercise. So this person, as they get better, will come out of the brace and they'll go through more range with their knee, bending it and straightening it. They'll start to pedal on a bicycle so they can do lots of cyclical loading, repetitions without a lot of weight bearing. And then they'll start to walk and get some shock load through it, and they'll have to restore all of their balance and position sense, they call proprioception, and their coordination. And then they have to remember that their knee is part of a whole system that connects them to the ground, including their ankle and their hip. And then they remember they've got another leg too, and all those things have to work together. And then that has to connect to the rest of the body. And then eventually there'll be a time that's appropriate where the loading can occur on skis. And then that person is most of the way back to their pre-injury level, and they progress from there and hopefully get to a point where they're skiing that run another time down the track, and will have no limitations from their previously injured medial collateral ligament. And off they go. Now that process roughly takes around 6 weeks to get back to a healed tissue, but it probably takes another 6 weeks to get back to the fully functioning human with the healed tissue. So the reason I just say that now at the end is just to be realistic about not just the recovery, but then the return to function. And we do see that it's a very important component of soft tissue healing. It's not just the tissue coming good, but the person around it recovering all their strength and all their coordination and taking it all up to the speeds that they do their sport with, so that when they are back competing or training at their maximum, everything's working properly. Now, they do say peace, love, and no harm. So the harm I won't spend a lot of time on, but heat obviously promotes vascularization, but it can do it a little bit too quickly and it's really hard to control. Alcohol is a big vasoconstrictor. I'm probably talking to the parents in the room and the over 18s about the alcohol. The alcohol also can impair our thinking, and that might affect our behaviours, which is an important protection. Running is interesting because we're talking about exercise that is not optimal for the tissue at its state of recovery. So that's what the R means. And massage represents those passive treatments that really aren't particularly helpful when compared with more active, optimally loaded exercise strategies. And if all of that goes out the window and you're thinking, my goodness, peace, love, harm, I can't remember what I'm supposed to do, just call the police. And the police is a really abbreviated summary of all that: protection, optimal loading, ICE for pain relief, not for anti-inflammatory, and your compression and elevation. So if you cover those off, you're going to do a really good job in your acute soft tissue injury management. Beck, have we got any questions?
We have one more question from Victoria again. She's asked, what do you think of electric muscle stimulation?
That electric muscle stim, it can be done with surface electrodes. It can be done with needles stuck into the tissue. There's heaps of variations on the theme. They're all under the category of transcutaneous electrical nerve stimulation. They are often given as a passive treatment. And so you've heard me mention the value of passive treatments isn't that high. But if it's a stimulation that's combined with some muscle activation or some movement, then you may be able to enhance the effects. But muscle stim on its own passively, I wouldn't put a lot of stock in that one. And if I was comparing the two, muscle stim over exercise, I'd choose exercise every time. But if you've got a stim and you want to try and maximize the value, combine the two. Good luck to you.
Lovely. So Victoria said thank you for both of her questions and the answers.
I wonder if Victoria's studying this at school and getting some of her homework covered off here.
Yeah, she's asking some good ones.
So I wonder in the last few minutes if there's any further questions about the anti-inflammatory medication, or, you know, when do we use ice, when do we not use ice? Man, it sounds complicated now. Well, that's what research does to things. When we start to really look closely, we realise it's a bit more complicated than the basic old rice regime, but we can be a lot more effective in how we manage our soft tissue injuries. Of course, we try to minimise the severity of them or happening at all if we can help that.
We have another one for Crema. She's asked, how much will the recovery delay if you get back to sport too early, or will it take you back to the beginning? So will it delay or take you back to the beginning?
Yeah, so I've got the sense of that. So if we just adopt the approach of graduated and progressive increases in, resistance and speed and endurance, all of the qualities that we're looking to develop with our training, and we gradually increase those, then that means each jump that we take forward isn't a really big one. And so the chances of doing too much too soon are minimized. And so if you wanted to try to apply a rule of thumb, you could say that an increase of more than 10% on what I've been doing over the last 3 days might be too big a jump. So if I've just been resting and doing light exercise at home just to help facilitate the healing, and I still have a bit of pain and swelling, well, it would probably be an obvious thing then not to jump straight back into my sport, because that's way more than a 10% increase on what I've been doing. But if a week or 2 or 3 later, I'm now moving more normally, I don't have any symptoms, my range is there, there's no swelling, but I haven't really done anything with a lot of resistance yet or speed, well, it would make sense to pick the most important one of those and add that in next. So let's say it's resistance. So that's where we might be in the gym doing some resistance work. Get your strength back, get your symmetry between sides if you've lost a bit of that. Then think about, well, to do this properly in my sport, I need to have this strength, but I have to move it quickly. That might be when you add the speed. And when you've added some speed, the next jump forward might be adding some direction change. And each one of these changes is added as about a 10% maximum increase on what you've been doing on average for the previous 3 days. And then you'll find yourself saying, well, I'm pretty much doing in my rehab what I would be doing for my sport. And then you're ready to go. What we really think is important is that if you haven't demonstrated in your rehabilitation, in your recovery, all of the requirements of what you need to do for your sport, you're probably not ready for your sport. What we don't want you to do is have your recovery quite removed from the sport demands and then roll the dice when you go out to do your sport, because you really don't know, you haven't tested anything. So you're really smart with your injury management and recovery if you've built up to almost reproducing what your sport is. An example of that for skiing, slopestyle skiing, for example, would be trampolining, acrobatic skills on the mats, jumping and landing, jumping with twists and landing, fast feet, good endurance type, speed endurance, things like intervals on the bike that might be the same length as a slope style run, and you've put all the pieces together of what you're going to have to do on the slopes. You've been skiing, but you haven't been in the park yet. So you've got all these things covered off. So then it's like, okay, well, it's only a small increment now for me to go into the park and do some basic features, do some low jumps, do some switch skiing, do a little bit on the rails. And I can do that with every confidence because I've proven that I'm ready. And that's a really good attitude to take into your injury management, not to be in a rush, but to be really smart and sensible with doing all the things you need to get there. And you will get there as soon as you should.
Well, Amber's had asked another question. She said, how long on average would you recommend waiting before you return to running, specifically after injury or surgery?
Well, that's where we're really in the individual stakes. Depends a little on, what the surgery was, what the capacity was beforehand. But very rarely, if you've had a lower limb injury to your knee or your ankle, would you be running before you could hop on one leg? And you wouldn't be hopping on one leg before you could balance on one leg, and you wouldn't balance on one leg before you could stand on that leg and do some strength on that leg. So can you see how I want to answer the question by building up to running, and then you'll be running as soon as you should be? What we know from the statistics is, on average, it's somewhere between 4 and 6 weeks post injury where you might be able to start, incorporating some running type activities into a standard recovery. But, some surgeries require immobilization or protection for 6 weeks. And so you won't be running then. So, there is a range, but the principles are, if you want to run, make sure you can do all the things that are precursors to running, and then the running will be easy.
Sounds great.
What else did you got?
I've got one more from Victoria. I think from memory, actually, she might be recovering from an ACL reconstruction. So her question is, for ACL reconstruction rehab, what is the optimal time for return to sport with reasonably normal chances of re-injury? I'm 15 now.
Yes. Okay. So yeah, ACL injury is actually one of the most researched of all the sports injuries. And so I would say, without having this session taken over by you and your ACL recovery, I will say that being your age, being your gender, female, I think, is that right?
Yep.
These are very important considerations into how important your recovery is and how diligent you are with it. There are some important milestones along the way that statistically show us that people that try to return to sport after ACL injury before 6 months have a terrible time. Their chances of re-injury are very, very, very high. It reduces a little bit at 9 months, but not much. It's better at 12 months. And after 2 years, it becomes a little more equivocal to the other side. But we don't keep people out for 2 years. So at some point, we have to weigh everything up, the risks and the benefits, the goals and the costs of trying to achieve those goals. And we make a really informed, educated decision that's appropriate for that individual and their circumstances. But being in a rush to return to sport, use that as motivation. Goes for everybody, but don't miss important steps because you're trying to be on a timeline. The ACL rehabilitation now is goal-based. You need to achieve certain criteria before you can move on. Some people achieve that a little faster than others, but it must be achieved before you can move on. And what I will say, the single biggest effect determinant on a successful ACL injury recovery is fully completing your rehabilitation program and being cleared at the very end of it. That has the biggest influence on the success of your outcome. So good luck with your ACL rehab there.
Yeah, and Vic, she said sorry, but Victoria, you don't have to be sorry. It's great to have some real life examples.
It does.
Obviously, very much in the thick of it at the moment. So thank you for asking some great questions.
Yes, thank you.
Yeah, along with Amber as well, and Crema. So thank you very much. So I think we might leave it there for the night. If anyone has any additional questions, feel free to reach out to myself and I'll pass them on to Caine. And yeah, so thanks again, Caine. This is the last time we get to see your lovely face for this year.
I can't believe that's 9 and you've still got people showing up. So good on you guys. I hope there's been some useful information throughout the sessions.
So it's great. We've got one more left, which is around social media next week, which is a really important one. For those that don't know, for those wanting to get into NSWIS, they actually check out your profile. So if you wanted some tips on how to present yourself accordingly for a lot of reasons, make sure you join in next week. I'll send that information out on Thursday. So thanks, Caine, again. This is recorded, so it'll be uploaded onto the website next week for anyone that wants to rewatch it.
Oh, at your peril. Thanks, guys.
Thanks, Caine. Thanks, everybody.
Thank you.
Thanks. See ya. Bye.